Thanks very much. It's always alarming as a consultant when you see people who you have had as SHOs or registrars over the years, and some of them, I believe, even from the other side of the world, which is quite interesting to see. Anyway, I will start with my presentation. So this is FRCS style. It's about cervical spine trauma. Now, it's not going to be exhaustive by any stretch of the imagination, but it will include two of the high yield topics which come up in the FRCS, and they include C2 fractures and subaxial fracture dislocations. This is not the textbook of cervical spine injury. It does, however, give you the opportunity to hear in some detail the kind of conversations that come up, and also the sort of questions that get asked, and specifically the things that you'll be expected to discuss. And then we'll, as we said, we will go through some different points of how to answer questions with regards to the FRCS as well, and some top tips, hopefully. The other areas notable by their absence that you do need to cover: C1 fractures can still come up, although rarely. Subaxial vertebral body fractures are also part and parcel of the trauma setting, however, less likely, it seems, through past questions. Spinal cord injury is something that you can be asked specifically in basic science, or indeed in the trauma setting. And ATLS management, I mean, obviously never forget that that's an important part of everything that you do. Sorry, getting used to the controls. So we'll start off with C2 fractures, and it's a bimodal distribution. You tend to see that the young, they're very high energy. These are the people that tend to do something silly, throwing themselves off things that are too high or into things that are too shallow. And then they tend to get C1 fractures more than C2. So the tombstoning phase that went through about 4 or 5 years ago was rife with C1 fractures. And then we have a different pattern for the C2 fractures in the elderly, where or upper cervical spine, where you tend to see more C2 than C1. Now, if you think about why that is, it was taught to me by one of my fellowship supervisors. If you ever look around on planes, if they're ever allowed to fly again, at people when they fall asleep, most of us, if we fall asleep on a plane when we're sitting up, our heads fall forward, don't they? And if you think of that movement and where it occurs, it tends to occur in your upper cervical spine around the C1, C2 joint. Now, if you think about C0, C1, sorry, and C1, C2, if you think about an elderly person, they tend to sleep completely upright because their neck is so spondylotic. And where it's spondylotic, it tends to fail at the areas where there is the most amount of movement. For example, around the level where there's the most mobility, which is the C1-2 articulation, which will be lateral rotation. And it takes, the C1 takes the odontoid peg with it. And always remember that the areas of the body that have the most mobility because of their anatomy are also the most prone to injury because they're the most unstable. So less bony constraint tends to lead to it being more liable to injury. The young versus the elderly are two very different beasts, and you have to equally bear that in mind when you are treating the patient. You've got a fragility fracture on one side as opposed to a very high energy injury, which is often associated with polytrauma in the other. They tend to be hyperextension or hyperflexion injuries. And in the cervical spine, you see that about 30% of all spinal injuries are incurred there. And that's because of the great big pendulum of the head wobbling around relatively unsupported on a small stick of spine. C2 amongst those is the most common. And then 50% of those are odontoid process fractures. And 50% are and remember, sorry, with your rotation and your movement and hence the mobility, 50% of your cervical spine flexion extension occurs at C0, C1, and then 50% of the rotation of your neck occurs at C1, 2. The other levels make up the remaining 7% per level of the spine. The anatomy is quite common, and it's relatively common to be past one of these. And it helps you to also understand the relative instability that can occur as a result of, why is my hand up? Sorry, there they are. Is that my hand or is that someone else's? The relative instability that occurs where you've got the C0 and C1 articulation up here with the very strong ligaments that attach it to there. And then you have your C1 vertebral body and your C2 with the odontoid process that actually is embryologically probably a remnant of the vertebral body that gets of C1 that gets left behind and then gets stuck onto C2. Across the back, this is a PA view of the bony anatomy. You can see the same ligaments, but then you've got this very important transverse ligament. And therefore you can understand why, when there's a fracture across the base of the odontoid process, across here, why the odontoid process goes with the C1 as it subluxes. Because these joints here, the facet joints or lateral mass joints here, as it rolls forward, that can sublux and there's no longer any constraint. And these capsules are really very fragile and flimsy, so they don't really control it. You also have got a little bit of this is a useful diagram to tell you the different nomenclature of the fractures that can occur, and it's all color coded. The commonest one being the Jefferson fracture, which is the burst with an axial load of the head essentially being squashed on top of the C1, which blows out the lateral masses either side. It's a ring. It tends to fail in 2 points and therefore can injure then. Also worth bearing in mind that when you do have that separation, that this ligament, the transverse ligament, can stay intact or it can tear or move apart, and therefore you have a very unstable situation if you've lost your transverse ligament integrity, because you've got no ability, or the alar ligament, you've got no ability to control the dens against the anterior arch. So you've got your two classification processes, classifications here, and it essentially boils down to your odontoid process versus your pars intra-articularis. The classification system for your odontoid process being the Anderson-D'Alonzo, and then you've got the Levine-Edwards classification across on this side. The odontoid process is relatively straightforward, and it explains usefully the relative stability and also the relative likelihood of union of these. And we can go on a little bit later to the reasons why that's important. The important thing with your Levine-Edwards is essentially boils down to the disc and the subluxation. So your disc is intact here, and we're talking about the C2-3 disc here. So the C2-3 disc is here. In 2, by definition, the disc looks partly injured and angulation is your modifier. So you can have a 2A here where it's tipped very far forward. And you can see that angulation has increased. And then a type 3, you have an associated bifacet dislocation as these have subluxed off. So the facet joint sitting here and it's subluxed across the areas it's moved forward. So that's your type 3. Your Hangman's, which is bilateral pars intra-articularis fractures, it tends to be a hyperextension injury which fractures through the pars, and then you have a flexion moment which causes your PLL to injure and the disc injury after that. So you get the extension followed by the flexion of the Hangman's, and it doesn't take much imagination or many Hollywood films to make you realize that's probably a fairly accurate mechanism for that to occur. So a general rule for your initial management and going through tips for this with how you would approach anyone with a spinal injury, you always approach it with an ATLS approach. Significant distracting injuries can occur and associated injuries. And you have to remember that specifically a Hangman's fracture, 30% of them have an associated other C-spine injury. And therefore, you should always make sure that you approach everyone in the ATLS walk that we're all used to. The immobilization can prevent spinal cord injury in a neurologically intact person, and it can also prevent it from a secondary injury in someone who already has a spinal cord injury. And the Asia chart, for those of you that aren't aware of it, which is the American Spinal Injuries Association chart, is now considered the norm for assessing people's spinal cord function and also for any level of spinal cord injury. It's a really useful documentation, and I implore anyone that has seen anyone with spinal injury to use that, timestamp it, put it in the notes, because it's incredibly useful, and it's actually what most of the spinal cord injury units in the UK certainly will use as well. Imaging is always an important aspect of cervical spine injury, and CT is very important, and also an MRI scan. CT obviously revealing the bony injury extent in the MRI scan, looking at the cord itself, whether there's any cord contusion, and also looking at whether or not any discs are injured and the location of the disc. the bony anatomy and the vascular anatomy of the cervical spine is relatively consistent to the level of C2. After C2, the vertebral artery, all bets are off. It can do all sorts of weird and wonderful things. And also, as you know, the brainstem supply runs off the vertebral arteries, or they contribute to it. And therefore, you have to be fairly sure that those are intact before you start considering doing anything to them. So it's always worthwhile including CT angiography. And so it runs through the intervertebral foramen, and it's from C6 up to C3. It can go through C2, it can wrap round C2, and then there's a rather tortuous course around C1 that lies over the back of the lateral mass before they coalesce higher up within the skull. The Levine-Edwards, and this is shamelessly stolen from Ortho Bullets because it's probably the most reliable and most UK-centric way of treating these fractures, essentially boils down to the classification. So it's one of the classifications where it is incredibly useful as it guides treatment. Now, with one, you can use a semi-rigid cervical orthosis for 6 to 12 weeks. And by that, I mean your Aspens or your Miami J's. You obviously want to perform radiographic follow-up to make sure there's been no subluxation. Your twos reduce with traction, and then you can use a halo vest for 6 to 12 weeks, or you can perform an open reduction internal fixation, or you can do a C2-3 anterior cervical discectomy fusion, or you can do a C1-3 posterior fusion. Essentially, it probably needs to be stabilized in some way. In the halo vest and traction, you're relying on bony union of itself, secondary union. However, with the other methods, you're relying on fusion of itself or fixation and primary bone healing to cause that. Be very wary, and the importance between differentiating between 2 and 2A, because traction with 2A can cause a lot of problems, and you can cause cord injury because of the dislocation. So you should avoid using traction in a 2A. Hence, it's important to identify whether or not that disc is injured and gapped open, and also what's happened to the angulation there, because reducing it can pinch off the cord. And then 3 is open reduction, and posterior fixation tends to be the method because you have to reduce those facets to fuse across the back. So just some examples here of the various types that you can have affecting it. So you can see here where there's subluxation across the 2-3 joint. You can see here a pars fracture, and you can see very nicely where the vertebral artery runs, and across there as well you've got the pars intra-articularis fractures. But even here you can see the difference in sizes of the vertebral artery foramen, and therefore you can also realize that the anatomy is incredibly variable, hence the need for a CT angio in a lot of these cases. So moving on to your odontoid process fractures, broadly speaking, it relates to the classification again. Now, this is young and old included, and I've tried to subdivide it slightly here. The important point here is that your risk factors for non-union occur mostly with your type 2 fractures. There are several reasons for that. There is the relative porosity of cancellous bone within the center of the odontoid process. So there's a high cortical to cancellous ratio, which doesn't lend itself well to bony union. There is also retrograde blood supply, and the same as the scaphoid, the same as the talus, there is often a problem with union across these bones. And also it's in a synovial joint itself. So the C1-2 joint around the level of the odontoid process is synovial, and that has entrainment of synovial fluid as well, for example. And that also explains why in severe rheumatoid arthritis, you've got such severe C1-2 instability, because that synovial joint would develop a huge amount of pannus and erode those ligaments, leading to a C1-2 instability from that perspective. Now, a type 1 can be confused with an osodontoideum, and therefore it is often treated non-operatively. A semi-rigid cervical orthosis, an Aspen Miami J, is the treatment, I think personally, mostly for the benefit of the surgeon that's looking after the patient. And in reality, you could potentially leave them free However, let's just remind them that they've hurt their neck and that they're going to need to be immobile and be careful for 6 weeks. But in reality, they're a very stable injury and are unlikely in the majority of cases to move. Type 2, the management differs significantly between the young and the elderly. A young person, a halo vest or closed reduction internal fixation, and that's the anterior screw or screws that can be placed across to cause direct osteosynthesis. Obviously, open reduction is very difficult. It's not impossible, but very difficult with regards to this odontoid process against the body of C2, but it is done, but it's usually a closed reduction. And then failing that, there are the various modalities of C1 to 2 fusion. In the elderly, a cervical orthosis is occasionally an appropriate option. And this is where part of your exam technique comes in, because you equally have to have an appreciation that a cervical orthosis is not a benign treatment for someone in the elderly, and they are associated with significant pressure areas. They also tend to collect cornflakes quite well, rather than actually providing any stability for the patient's neck. But again, it's a marker of a disease process, the fact that they fall, the fact that they're osteoporotic and have a spondylotic neck. But certainly you should stay well away from the German perspective of putting these people into halo vests or close reducing them, because there's not a huge amount of evidence that that's beneficial. And actually there is decent evidence now that the mortality of patients with C2 fractures in the elderly is probably worse than a hip fracture if you look at them on a similar Nottingham hip fracture scoring system or on a frailty index. Type 3 are good. You've gone through the cancellous bone at the base of the odontoid process. You're through into the body proper of C2, and therefore you've got a lot of bleeding cancellous bone, and a semi-rigid cervical orthosis often does quite nicely. In your type 2s, you have additional risk factors for non-union. So the patient factors we discussed, the age, for example, smoker, diabetics, and if they have any other immune suppression. Then you have other fracture characteristics, which include their angulation being more than 10 degrees, either in any direction, displacement of more than 5 millimeters, comminution, and a fracture gap of more than 1 millimeter. The important discussion point for that is that all non-unions are not symptomatic. And by that, I mean to say that if a patient doesn't have radiographic evidence of union across their C2 fracture and they are an 82-year-old, you actually, if you perform flexion extension views, may find that they are stable because they've gone on to fibrous union, and therefore chasing bony union for the sake of operative morbidity is not necessarily particularly helpful. So it's a discussion with the patient and with the patient's next of kin about the fact, yes, it might not heal. However, there's a good chance that it will be stable enough to live the rest of their life without any complications. And spinal cord injury in the elderly is remarkably rare for this type of injury, because they tend to be canal expanding rather than canal narrowing injuries. Here we've got some decent CT scan of the different fractures. So you've got a C type 2 across there and a borderline 2-3, probably more a 3 because it does extend across the body on this side there. And there you've got the retrograde blood supply. There is an apical arcade across there, but the majority of the blood supply runs in through the base, and therefore separating those, same as a subcapital hip fracture, and displacing it tends to lead to death of that. And it does arise from the vertebral artery. That's been asked before. These are various types of fusion methods. So you have transarticular screws, which is the Mergel technique, usually supplemented with a bone block and sublaminar wiring at the back across here. And then you have the Gold-Harms technique here, which is essentially pedicle screws and lateral mass screws. So pedicle screws of C1, lateral mass of C2, and rods across there. These are from AO, and the vertebral arteries, you can see that's what the textbooks would tell you they do, but I've seen them on this side of the transverse process. I've seen them coming inside, wrapping around. They do all sorts of weird and wonderful things. So angiography is certainly vital if you're considering doing posterior surgery at the C1-2 level. This is mostly just to show that halo vests kill elderly people. They cause huge amounts of morbidity. They cause pressure sores. They cause enormous issues. They cause pressure areas even underneath the sheepskin lining. And they are incredibly disabling for people. And lots of statements from various national bodies with regards to spinal surgery and spinal trauma show that halo vests are in fact used less and less, not just in the elderly, but also in younger cervical spine trauma, with the majority of people now replacing it with a semi-rigid cervical orthosis. It is, however, still a skill that is expected of someone sitting the FRCS, and therefore it's one of the things you need to be able to reel off is how you would put on a halo ring and halo vest. So we'll move on to subaxial fracture dislocations and talk a little bit about that. And what we have here is the most common ones, which stands to reason, is around the C6 or C7 vertebra, so be it C5-6, C6-7 or C7-T1. And that stands to reason because that is the area where you have transition of stiffness from the relatively mobile cervical spine coming down to the relatively immobile thoracic spine. And at levels of transition of stiffness is where you tend to have injury, again, because of the pendulum effect of the head and the fact that it's stuck on top of the spine. And eventually the thing that will fail is where the stiffness suddenly increases dramatically. They tend to occur from blunt trauma. You can equally have road traffic accidents, road traffic collisions and falls. And a nice way of thinking of them is that the energy required is roughly inversely proportional to the patient's age. So therefore, a fall from a standing height not unreasonably cause a subaxial fracture dislocation in someone in their 80s. However, someone in their 20s, you usually have to do something slightly silly at speed with the assistance of a car. The forces dictate the type of injury, and we'll come on to that slightly later. But remember that all of these also are associated with other types of fractures, including teardrops. And there are two different types. There's the flexion and extension type. The extension type tends to be a small avulsion that comes just off the inferior corner of anterior inferior corner of the vertebral body on the sagittal slice. And then you get your flexion type of teardrop, which is actually a large fragment which comes across because it shears off as the flexion moment occurs. You can still have burst fractures, and you can also have compression fractures occurring in the subaxial spine as well. So mostly because it's the hot topic and the high yield topic, we'll talk about facet fracture dislocations. And you have to bear in mind that there are two very different types of mechanism. Now, nothing's obviously perfect in real life. However, it tends to be associated with a flexion and vertical loading moment that causes a bifacet fracture dislocation. So when the neck is flexed, then there's a vertical load which unhitches the facets and therefore ruptures the disc more often than not, causing that bifacet dislocation. A lateral flexion with a rotation, a lateral flexion opens one facet, and then rotatory loading can either punch off and fracture across a facet, or it can hitch a facet over onto the other side. And that tends to cause a unifacet fracture dislocation. Now, it won't surprise you to see that this is the same approach as I had before, and these are the things that you need to be able to tick off in your Viva answer. A tip that I like to teach on the courses that I tend to teach on is, if you are approaching a Viva station and you don't know whether or not it is a Viva about ATLS or it's a Viva about spinal cord injury or a bifacet or unifacet fracture dislocation, a really nice way of starting it is to say, I would approach this patient in accordance with the ATLS approach. And then I'd say, however, can I assume this is an isolated injury? What you've done there is you've ticked the ATLS box, you're safe. And then you've also turned around and asked the examiner, essentially face-to-face, saying, am I talking about the spine or am I talking about ATLS? And the answer that they give you next will tell you which direction the Viva usually needs to go. So if you say, I'll approach this patient with accordance to ATLS, can I assume that this is an isolated injury? And they say no, then you know you've missed something in the ATLS approach. Well, they want to hear some buzzwords, be it C-spine immobilization and airway, or if they say, yes, it's fine, this is an isolated injury, you can park the rest of that stuff and then you can move on to the meat of your injury that's faced in front of you. And it works for other injuries as well, be it a complex femoral fracture, a pelvic fracture, for example. Again, always include the ASIA chart or an ASIA assessment rather of the patient. Now, the question that is asked most frequently with regards to with subaxial fracture dislocations, be they unifacet or bifacets, is when does the imaging happen? My answer to this, usually for the sake of the exam, is the hospital you work in for the FRCS is the best hospital that has ever been built, which has 24/7 MRI scanners, it has 24/7 theatre, and it has access to absolutely everything. Therefore, your answer should always be emergency imaging. This is from the cervical spine trauma group, which is headed up by a guy called Alex Vaccaro in New York. And this is the algorithm that they have proposed as your treatment for cervical facet dislocations. I disagree with this slightly, mostly on the grounds of the fact that you will never regret getting imaging. But the essence of the imaging conundrum is whether or not the disc has slipped within the canal and whether or not it requires extraction prior to surgery from the back to unlock the facet joints. And we can go through that slightly later. But in my mind, someone who has a serious neurological deficit, I don't believe that there should be emergent closed reduction without getting an MRI scan in the UK practice, because an MRI scan can happen relatively quickly in an emergency situation for someone with a spinal cord injury. And I think, therefore, that should usually be your answer. But bear in mind that this does exist, this algorithm. So my algorithm for treating this is to say these injuries should be managed in a tertiary centre equipped to handle major trauma. And if you don't work in one of those, you are perfectly welcome to say my unit is not one of these. And this is the next most important sentence after the can I assume this is an isolated injury, is to turn around and say, however, the principles of their management are as follows. So you don't want to be the kind of person that says, I don't know what I'm doing, I'm not going to talk about it, I'm going to send it up the road. You want to be the person sitting in the exam that says, I don't do this regularly, which is your warning shot to say my unit isn't one of these. But then you say, however, I do know that the principles of their management are as follows, and you treat the life-threatening injuries first, and you get an emergent CT angio and MRI scan, with the question of being where the disc is. The variants to this are, if they're unconscious and you can't assess their neurological status, well, that's easy, you get some imaging. They're conscious and they're intact, that's again very easy, you get the imaging, because you can only stand to make them worse. They're conscious but they've got a complete spinal cord injury. To me, I would still get some imaging, because you want to know what is causing compression. Is it disc? Is it epidural hematoma? Is it something else? And that's a really important thing to me, to want to be able to know what's going on and also what you're going to expect. Conscious with a stable neurological deficit, I think that's still again appropriate to get your imaging. And if they're conscious but they've got a rapidly deteriorating neurological deficit, this is where you maybe try closed reduction, but ideally again, get immediate imaging. So on to the next bit of how you reduce them. There are two different philosophies for this. You can put Gardner-Wells tongs on, and they attach to the occipital protuberance just behind the earlobe, and you essentially apply increasing weights over a traction ring in line with body weight. I would suggest that that's potentially a failure of analgesia in the case of the reduction, rather than necessarily requiring more brute force. It's done in theatre under fluoroscopy, and you do repeat neurological examinations throughout after every weight that you add, and you give it time, at least 5 to 10 minutes after you've put on the extra weight. And the patient is awake, however, they have analgesia and you have an anaesthetist present, because if it all goes horribly wrong, the person who's going to sort it out needs to be the person who's putting the traction on to resolve it. What do you do if they worsen? You take the traction off and you see if they improve. And if they don't improve, you get an urgent MRI scan. There is an often quoted degree of subluxation, and I use the word probably here as quite a heavy caveat. It's talking about in the sagittal view, and in the sagittal view, it's talking about the degree of listhesis, the degree of spondylolisthesis. If it's 25%, it's probably a unifacet if it's 25% or less. And if it's more than 50%, it's probably bifacet. However, there are lots of different variations to that. If you look at the plain film that's in the center of the screen, you can see the 2 red lines. Unfortunately, they're quite thick, but what it does show you is if you look at the longer of the 2 red lines, that lines up to the spinous processes of 6, 7, and then down to the thoracic spine. The smaller one next to it lines up with the spinous processes of the upper cervical spine. And as you can see, there's been a step change, and that's because there is a rotational abnormality there. And that stands to reason that obviously one of the facets has hitched or has moved. In this case, you can actually see it here on the AP, that there's asymmetry and that's subluxed. And therefore, there's a rotational moment which has moved the spinous processes. Now, if you look at the on the gap here, however, if you imagine that this is a bifacet on the lateral side, if you imagine that there's a bifacet dislocation, there's no reason why the spinous processes should change their rotation in this plane. So they would normally stay in roughly the same position. So that's just an additional way of assessing that. So your treatment depends very much on where the disc is and whether or not the facet is locked or fractured, and also the status of the posterior ligamentous complex. Now, the disc is the important thing, because if you reduce the fracture dislocation or the locked facet, and you've got disc which is wedged up and in and behind the cranial vertebral body, when you reduce it, you push that disc back and you knock it against the spinal cord, and you can potentially worsen or cause catastrophic spinal cord injury. Hence why you need to know where it is. If the facet is fractured, that's pretty good news, because actually with a little bit of traction, it usually all lines up quite nicely. If it's locked, then you have a different situation, and that's where reduction becomes quite important. The status of your posterior ligamentous complex, a rotational injury to your cervical spine in the form of a unifacet fracture dislocation doesn't always injure your posterior ligamentous complex, because it puts it through torsion rather than through tension, and it fails under tension rather than under torsion. So you can often have an intact posterior ligamentous complex in someone with a unifacet fracture dislocation or unifacet dislocation. However, with a bifacet, by nature of the fact that both of the joints are subluxed, you often have a posterior ligamentous complex injury, and you can see that with gapping of the spinous processes as they move apart. Now, knowing where the disc is important, because, oh, sorry, my spelling is terrible there, but if you have a disc that is going to push back against the spinal cord when you reduce it, you obviously can't reduce the fracture first, and therefore your first port of call with surgery ends up being your anterior cervical discectomy, to go in and to free out the disc and remove it from causing any potential problem when you reduce it. You then have to turn the patient prone. You do posterior release of the facet or reduction. In some cases, you actually just have to burr away the locked part of the superior articulating process of the vertebra below to allow it to reduce, and then perform a posterolateral fusion with usually lateral mass screws or with pedicle screws. You then turn the patient back over again, and you put in a usually bone block or an allograft into their disc space, and then you plate across the front of it to get them to fuse in the fullness of time. But that obviously is a worst case scenario, but it all depends, as you can see, on the position of the disc. Because if the disc isn't anterior, you can actually say, well, this is fine. I'm going to go straight to the back. I'll do the posterior release of the facets, do the fusion, then go to the front, remove the disc, and put in a cage or a graft and a plate at that level. So I think if we're happy, we will move on to the case, unless anyone wants to tell me that I'm not allowed to do that. You've got some questions, yeah. or do you want to do the case? What do you want to do?
Do you want to do the questions first, and then we'll do the case?
Okay, yeah, sure.
Yeah, is that all right? Joe, are you ready? I can't see him. Joe?
Should we go on to the case then?
Yeah, let's go to the case then.
Okay.
Sorry, Will, if we can go on. Thanks.
That's all right, no worries. So, now do I go back? Right, so I'm going to have to read this one. So this is a 36-year-old man who was allegedly run over by his partner in a car park that morning. I think the truth of the matter is that the partner met the girlfriend. It was about 6 o'clock in the morning, and the patient was unresponsive on the scene, and bystander CPR was commenced. There was a ambulance paramedic crew that arrived who witnessed poor quality CPR, but the pulse was present, and there were ineffective respirations, and the patient was clearly shocked, and there was a rapid sequence induction at the scene. And it was also felt that there was decreased air entry on the right side with hypotension, so finger thoracostomy was performed on the scene. So it's a real case, and you can see there they've got the chest tube in place and the ET tube in situ there. Now, real case, obviously significant injuries. However, we're going to move on to the important part of the bit that we're talking about. However, again, the same response. Sorry, I've just got stuff in the middle of my screen, so I'm just trying to move it out of the way. Is again always ATLS approach, distracting or associated injuries. In this case, you obviously can't assume it's an isolated injury, but you can ask if you can assume that this is the injury that we're discussing. And then your next question is, what do you do next? So we've got our CT traumagram, which shows our mid-sagittal slice CT on the far left of the screen. You have two parasagittal images there with a through the facet joints there. And as you can see, those facets have gapped open on the furthest to the right, and there's a fracture through the one on the middle image there. If you look at the far left image as well, you can see that the disc space is widened posteriorly. It's hinging at the front. There's also significant anterior soft tissue swelling. And if you look at the gap between the spinous processes posteriorly, there is a significant increase in that gap at that level, which is the 4-5 level that we're talking about. So things that I personally hate and think that is a very good trick to, or very good habit to get out of, is don't say the most obvious or the most obviously abnormality is, because if you say it and you get it wrong, you look stupid because you've missed something even more obvious. So get into the habit of saying, being confident, if you are confident, obviously, and say there is. So going back to that one, you would say there is increase in disc space height at the back of the C4-5 level. There's an increase in the interspinous gap at the corresponding level. There is a fracture through one of the facets, and there is a perched or significantly subluxed facet on the contralateral side. So then we come on to this investigation, and this shows how important it is. And this is a CT angiogram. So you can see here in the intervertebral foramen, you've got a nice view there, and you've got a nice view there of an artery. And this is obviously at the higher level because it's at the level of the mandible. And this corresponds to roughly the C4 level. Now, the interesting thing here is there is absolutely no flow lower down. So this is below the level. There is no flow there. So this is retrograde flow coming back through the vertebral, through the circle of Willis, and then passing back down through the vertebral arteries. So there is no flow at this level. And putting those things together, it stands to reason that probably what's happened is this patient's had a vertebral artery dissection or vertebral artery complete occlusion during the trauma. Because remember, it's the same with every accident and every displacement you see, it's always looked worse than it did at the time where you see it in the scanning. So his chin was probably against his sternum for a period of time at the injury. And therefore, he has almost certainly had a significant brain injury as well as having a significant cervical spine injury. The other important point to remember when we're looking at these injuries, remember we said we were dealing at the 4-5 level, is that there is also phrenic nerve innervation, and therefore there could be a significant risk of respiratory compromise as a result of this injury. Next, we move on to the MRI scan. In order from left to right, on the left-sided image, we've got a T1 weighted scan, where you can see the anatomy quite nicely. Middle slice is a T2. And important things to see on the T2 are you can see that the disc is injured, the posterior longitudinal ligament is injured. If you trace the PLL down the back of the vertebral bodies, you see that suddenly there is a gap and it's actually flicked up a part of the PLL. And you can also see that the anterior longitudinal ligament has ruptured anteriorly, and it's therefore, as he's flexed forward, it's peeled off the front of the vertebral body below, which is C5. You can also see some cord edema in this case. It's not myelomalacia in the acute setting, it's edema. And then at the back, you can see that there's, again, this increased interspinous space. The far right image is a short tau sequence of fat saturation image, which shows edema very nicely. And you can see how much that posterior ligamentous complex lights up, and it also accentuates the spinal cord edema there. And again, you can see that there's actually some hematoma that tracks further down inside the epidural space, or the intradural space in this case, with a cord bleed, or a cord a hematoma, sorry, present there, epidural hematoma. This shows you the degree of cord compression. As a general rule, the spinal cord, this is an axial slice, as a general rule, the spinal cord should usually look like a fried egg, with a round area of CSF, with the cord being the central yolk. And here you can see the huge amount on the stir sequence of the edema that's associated with the injured posterior ligamentous complex as well. And there also you can see where the disc has been injured and has been extruded through onto that side. So if we go back, you can see that in this case, if you reduce this patient, and say by some miracle he was neurologically normal, if you reduced him back down again, you stand a very high chance of driving that disc further into the cord, and therefore exaggerating his injury and his spinal cord injury, giving him a second hit. So what happened to him? He had, as a first stage, as we said, an anterior cervical discectomy. The interesting part here is that actually, as his anterior cervical discectomy was performed, because he was so unstable, it actually reduced his bifacet dislocation and therefore brought him back down again. So there wasn't need to do back, front, back, because it reduced him back down there. And therefore, as he was reduced into an anatomical position, he had the cage, or a bit of bone block in this case, put in with screws going into the vertebral body above and below, with a plate over the front. He was then placed prone, and then from the back, he had lateral mass screws inserted. This is the fractured lateral mass here, and therefore the anatomy is so distorted that they weren't able to place a screw at this level, but he had two above and one below on this side. As a tip for recognizing radiographs, lateral mass screws go out and then pedicle screws go in. So these are all lateral mass screws as they're heading outwards away from the spinal canal, whereas a pedicle screw, if you do use them in the cervical spine, they tend to move inwards. So some tips for recognizing these, as we've mentioned before, the posterior ligamentous complex and unifacet fractures aren't always injured. And therefore, it's whether or not you necessarily have to always perform 360-degree surgery. And by that, I mean anterior and posterior surgery. And I think there might be something coming up in the cases where there are some examples of when and when that's not necessary. And isolated nerve root injuries, when they occur due to a facet fracture dislocation, you rely slightly on the principle of an indirect decompression with the reduction of the fracture, rather than directly going and decompressing around that nerve root. The important thing to remember with spinal cord injury and with neural injury is that the damage occurred at the time of the trauma, and your general principle is to stabilize things, to allow things to recover and nature to take its course. As long as you free up the nerve and make sure that it's not under continuous direct compression anymore, then there is a good chance that it will recover at root level, unless there's been a root avulsion. Hence why indirect decompression can actually work quite nicely, because the ligamentous taxis that reduces everything allows the root and the cord some space to breathe, and therefore you are hoping that things wake up. Laminar fractures are an unpleasant beast. They signify in the cervical spine that there is a significant risk of there being a dural injury underneath it. And that is not something that you look forward to encountering when you're doing posterior surgery. Hence why indirect decompression, reduction of the fracture, and then fixation and fusion is often felt to be the most appropriate course of action, because a large dural defect in the cervical region can be very tricky to manage and can cause ongoing problems and certainly wound issues in the posterior cervical spine. Interbody selection, elite sportsmen and patients for trauma, I would always tend to use either allograft or autograft. Autograft would be tricortical iliac crest with plate supplementation, and that's because you are relying on them fusing, and therefore you want to be able to see that there is bony union across those across the disc space between the vertebral bodies. A metal cage doesn't allow you to do that, and certainly takes a lot longer, and PEEK or plastic spacers are notoriously bad for doing that. So certainly if you have these injuries in elite athletes that want to get back to contact sports quickly, you need to see bony trabeculae bridging the disc space, and therefore the best choice is autograft, although allograft can sometimes be utilised as well if you don't want the morbidity from the donor site. Your end point of your exam is to be safe in an emergency. The examiners are very aware that you are not a spinal surgeon. You are probably not going to be a spinal surgeon because you're all too sensible to think of anything as silly as that, and that you're therefore safe in managing an emergency and know the principles of managing an emergency. Please avoid being the phone a friend or refer everything consultant, because no one wants to hear that from the other side of the examination table or the examining room. You don't want to be the person that says, "Oh, I'm not sure, this is outside my remit, I'd phone my spine colleague." The way of getting around that to say, "I don't do this routinely, however, the principles of management are," is a way of just diffusing the situation. Be aware of the principles of management of spinal cord injury. My catchphrase for this is the principles of management of spinal cord injury are to prevent secondary injury. Hence, the patient needs to be managed on a high level care bed where they have invasive cardiac monitoring to ensure that they've got a decent mean arterial pressure. That usually means HDU or ITU. And also to stabilize the spine so that they aren't reliant on such intensive nursing care for mobilization and they can get up and get going. You need to know how to put on a halo vest. And if you haven't done it, say you haven't done it, but certainly be able to have read how to do it and describe how you do. And bear in mind that the person asking you a spine question is almost certainly not a spinal surgeon, and you probably know more about it than they do just before the exam. So have a little bit of solace in that. And there's some textbooks which are very good, and I recommend that you spend your hard-earned money on them.
Thank you very much, Will. So I think Joe now has some questions for us, so we'll move on to the questions next. And I second the books that were just recommended. I use them as well. So Joe, I'll hand over to you.
Hello, thank you very much, Mr. Keher. The brilliant presentation, and basically touched everything about the basis, especially the tips and tricks about how to answer in the FRCS exam. I have a few questions here. First, how to differentiate between a teardrop and an osteophyte fracture?
So they're sort of the same thing. So a teardrop and osteophyte type fracture tends to occur when you have extension. And what happens is across the disc space where you have that little syndesmophyte,
yes,
and again, call it a syndesmophyte rather than osteophyte, and where there's a small ligamentous avulsion or pull off, and it tends to be a hyperextension type injury where you just get that little pull off there. They can signify that there's significant instability in the patient if there's been a high energy mechanism. What we all tend to see is we tend to see it in these CT traumograms of very elderly patients. And therefore, I think it's reasonable, rather than putting those people through the rigmarole of an MRI scan, to perform flexion extension views of their neck at that stage. A proper teardrop fracture is usually a decent fragment, and it's of the vertebral body itself rather than a syndesmophyte. And you can see that because it extends into the cancellous bone of the vertebral body.
Right. So the second question will be, how long should a patient be allowed to be left in an extrication collar, and whether or not there is any literature to back up the time?
So no, there isn't. There is. I teach ATLS pretty regularly and involved in the in that, and there is an uphill struggle to take out the extrication collar now.
Yep.
And actually, certainly a lot of the pre-hospital services at present are now not putting patients in collars routinely. And certainly our pre-hospital service have got a lanyard that they put around the patient to say, I have not had my C-spine immobilized, that hangs around there just to make sure that people are aware of it. In terms of leaving people in them, they're horrible. They are utilitarian, but they really can cause significant issues. I would recommend getting someone out of them within a few hours, if at all possible. And obviously there is a BOSE guideline all about clearing cervical spines in the non-responsive patient that you all need to know again for the exam. But it's a short-term thing and actually falling more out of favour at the moment. I'm not aware of any literature as to how long you can leave them in for.
Thank you. And how would you decide the stability of the subaxial cervical fracture regarding the surgical fixation?
So that's tricky. I have done unifacets where we didn't even do MRI scans because of logistics. And actually, the feeling was that they were going to be stabilized in a collar for 6 to 12 weeks afterwards, and therefore that would allow the ligaments to heal up. And an MRI scan will give you a huge amount of information. And for the sake of the exam, if you're not going to get involved in the nuances of spinal surgery as a spinal surgeon, your answer should be, I would assess the posterior ligamentous complex with an MRI scan, which would help me to decide whether or not the patient required supplementary posterior fixation or fusion. And that's your safest answer. If you want to be pushed into it, then you can turn around and say, well, actually, it's a sprain, it's a capsular injury, rather than an avulsion of the posterior ligamentous complex. Probably I'll put them in a collar and I wouldn't back it up with the morbidity of posterior surgery. But you're knocking on the doors of 7s and definitely 8s if you're having that conversation with your examiner.
Yes, totally agree. And is it always the case that we need to stabilize anterior and posterior fusion?
So I think we've sort of just touched on that there.
Yeah.
No is the answer. And bear in mind that you are dealing with the level of instability. So obviously in the case that I showed you, there's a really obvious posterior injury that if you fix them anteriorly, you're hinging everything over that cage and that plate, and that's not enough. And for nursing needs, because you don't want to have to nurse this guy in a collar forever and do log rolls, fixing his neck and making him stable is still a sensible thing to do. So it depends. It's a case-by-case discussion, but your MRI scan will help with that.
And the last question just popped now. How can we decide C1, C2 stability or C2 stability in terms of the fracture pattern?
Yeah, so flexion extension views are still useful. It's a cause of great consternation for every radiographer in the world as you send someone down and say, take the collar off and get them to nod and extend. Yep. It's tricky, and your stability depends mostly on the fact that whether or not there has been a significant cord injury at the time of the injury in the elderly. So in the elderly patient, the general pathway for those of you who ever have to phone your friendly local neurosurgical department, they will almost always say, put them in a collar for 6 weeks to 3 months. Actually, the reality of it, as we all know, is they tolerate it for about a week, or they're non-compliant, or they have severe dementia, and therefore they take it off. And those patients don't come to significant harm. And it's probably because actually their spines are so stiff and spondylotic anyway that they confer a degree of stability. In terms of radiological assessment, you're looking for separation on the coronal view of the lateral masses if you're looking at the C1-2 interval, and then you're also looking for flexion extension movement, and you can look at the anterior atlantoaxial interval as well to see if that's increased, and also the PADI as well.
Yep, thank you. And is it necessary to get a CT angio for every C-spine trauma?
In the exam, yes.
Okay, brilliant.
You are safest. You have this wonderful hospital, like you see in whatever the American soaps. You can get whatever you want, and you will only regret not getting one. So a CT angio is a very reasonable course of action, and actually really doesn't take that much to do because it's a very fast sequence. It's very quick. The patient's been near the CT scanner already anyway, and it really can change your management. So for the sake of the exam, and you're looking for vertebral artery injury, vertebral artery dissection, and that's your reason. So you should do it.
I think that I can't find any other questions. If I missed any, please can any of the participants write it again, and I will ask Mr. Kefa. Thank you very much for now for answering all the questions.
No worries.
Thanks, Joe. Thank you, Will. That was a really interesting lecture. Yeah, I quite enjoyed that because I don't see a lot of spine where I work at the moment. But I remember revising it for the exams. So what we're going to do next is we're going to move on to the MCQ polls. So Ruth will share that for us. As I said before, it's all anonymous. So the sooner that you complete it, the sooner we can move on to a discussion of the answers. And then we'll move on to the best part of the evening, which is the Viva practice.
Should we start slogging through the answers? We've got 80% voted, or should we wait for the whole lot?
No, let's crack on, I think. Plenty
Okay.
of time.
Good stuff. So I think as you have picked up the first
Sorry,
ones.
Will. Hannah just needs to share the results just so you can see.
Oh, okay. Oh,
Yeah.
right, fine.
Hannah, can you share those, please?
Yep, it should be shared. Oh, it's got an error.
I can read them out if there's a problem.
In polling.
Oh, there we go.
Can you see everything now?
I think I can share results. There we are.
Okay.
I've just pressed share results. Can if someone could just stick their hand up or thumbs
Yes,
up
we
on?
can
Yeah,
see
you
them.
see it. Perfect. So as you can see, the first one's a bit of a sitter, and this is essentially just an assessment of your knowledge of the Anderson-Alonso classification of odontoid fractures. A type 2 being the commonest in the elderly, and being a high risk for non-union for all of the reasons that we went through. You've picked up on the medical school trick of always is a bad word and doesn't tend to apply in any exam answer, because medicine isn't an exact science. And type 1 would be the one that tends to be confused with an nosodontoideum, is unstable because of the configuration, tends to be commonest in the elder group, and doesn't always involve disruption of the transverse ligament. In fact, rarely involves disruption of the transverse ligament. So moving on to the next one, a C6-7 bifacet dislocation. Often has an intact vertebral disc, is incorrect because usually you've ruptured at least the posterior wall of the disc with that increased disc space. So it often has an injured intervertebral disc, is how I would phrase that if it was the other way. Is not associated with significant neurological injury. No, it can be associated with devastating neurological injury, and occurs following a lateral flexion moment. And that is the trick about differentiating between your bifacet and your unifacet. So a unifacet is a lateral flexion moment with a rotatory force as well. Often requires anterior and posterior surgery. Yes, for the reasons that we've been through, and whether or not that's anterior, posterior, anterior, or just posterior, anterior remains, or just anterior, posterior, sorry, is obviously a patient-specific problem, and it's beyond the remit of the exam, I would say, and would cause isolated lower extremity neurological deficit. Again, just a small anatomy question. Note, because if it's going to cause neurological deficit, it's going to happen at the C7 root level or the C7 level, and therefore you're going to get upper limb neurological deficit as well. Next one's a slight nuance of the Asia examination, and the Asia examination chart, for those of you who don't use it, is pretty prescriptive and actually is a very useful language. So I appreciate why some of you have gone for contestant number 1, being biceps motor function, because obviously a lot of people are taught that C5-6 is your biceps motor function. However, for the sake of Asia, that is a C5 motor root. That's a C5 myotome is your biceps motor function. However, your thumb, index finger, sensory function corresponds to C6. Wrist extensor motor function is what Asia calls your C6 myotome, and however, it's not your lateral elbow because that's your C5 dermatome. Triceps then being C8, sorry, C7. And then again, your small hand muscle function is quite vague, but usually is associated with T1 with your small hand muscle function with your fingers spreading. Wrist extensor motor function, yes, that's a C6 myotome. Thumb and index finger sensory function, yes, that's the C6 dermatome according to Asia. So the trick here is the Asia chart, and hence the way the question was phrased. Any points or questions about that?
No, I don't think so. But if any come in on the chat, we'll relay those to you.
Perfect.
Okay, that's great. Thank you so much, Will. So what we're going to do now is we're going to stop the recording.
Nikki, can I, sorry, interrupt?
Sure.
There's only one question on the chat. How would a CT angio change the management?
So CT angio changes the management in terms of whether or not you need to do an open approach. So if it's bilateral, you would probably need to perform repair of the vertebral artery, and you'd need your friendly vascular or neurosurgical colleague to come and help you do that. And that's quite an involved process. You can shunt it. You can basically do a paraspinal approach where you take down the intervertebral foramen and then you shunt across it. And that's to try and return part of your vascular supply. That's only if it's bilateral. If it's unilateral, it tells you where you've got to be really, really careful about not injuring the contralateral side. So therefore, your unilateral injury, first of all, if you go in and you are faced with a hell of a lot of bleeding on one side when you're putting in your lateral mass screws, it's probably not because you've caused a vascular injury. It's probably because there's been a dissection or an injury to the vertebral artery. So it just gives you a bit of advice about when a bit more information about when you're fixing and whether or not you need to phone a friend to be there in theatre with you to try and replumb this person.
Thank you.